fasciitis, or heel pain, is one of the most common ailments that I see patients for in my office. Patients usually will have, it starts out where their heel feels bruised, and they may feel like they stepped on a rock or something. But as it progresses, the pain will be, they'll have pain first thing in the morning when they get out of bed, pain after getting out of a car, sitting in the car for a while and driving and getting out, pain after sitting down for a short period of time or a longer period of time at their desk and then getting back up. So pain after periods of rest. Lots of times it can be worse at the end of the day or made worse with activity. Plantar fasciitis can be caused by many things. You try to look back at the patient and see what have they done when the pain began. It can be an increase in activity or a new activity. They could have gone to wearing some different types of shoe gear or older shoe gear that wasn't supportive. Weight gains can definitely cause the plantar fasciitis. Problems with your knee or hip replacements can lead to a limb length discrepancy or put excessive stress on the affected limb, leading to increased strain and tension on that plantar fascia. Certain foot types, so foot types that pronate excessively where the arch flattens, can cause increased tension on that plantar fascia. Definitely shoe gear is a big factor with the popularity of the flip-flops and the flatter type shoes and some of the shearling boots that don't provide any support. It definitely leads to excessive stretch and strain on that plantar fascia and that plantar tissues. So shoe gear modification is one of the biggest, or changes is one of the biggest causes. So the mainstay of treatment for plantar fasciitis is controlling the pronation. So we do that with supportive shoe gear and with orthotics. So getting patients to stop wearing flatter shoes, getting them to wear more supportive shoes with a little bit of a heel, midfoot stability, and I do go over supportive shoe gear features based on the patient each time they come in. Orthotics are really the mainstay of treatment. Most people get better conservatively with supportive shoes, orthotics, and beginning a stretching program. An orthotic is an insert that goes inside of your shoe that helps to control rear foot motion, helps to plantar flex the first ray, the medial side of the foot where the big toe is, to take the stretch and strain off that plantar fascia. So as soon as that heel hits the ground, it locks that foot in place and allows the muscles to function on a rigid lever and brings the ground up to your foot so your foot isn't collapsing down into the ground, causing the increased strain and tension on that plantar fascia. Getting patients to stop going barefoot or looking for more supportive shoe gear to wear inside of their house instead of just stocking feet or just slippers. Other treatments to help with inflammation early on can be oral anti-inflammatories. There is ice massage, so rolling your foot back and forth over a frozen water bottle or a frozen ice bottle, frozen water bottle or an ice pack. Can help to serve as myofascial therapy and cold therapy at the same time. There's stretching. So many patients think that they're stretching properly, but sometimes they're not holding the stretches long enough or they're taking the stretch too far. So they should be holding their stretches for about 30 seconds and stretching until they feel a little bit of tension but not too much pull, because otherwise they could actually be hindering their recovery and causing more damage rather than helping to improve their symptoms. There are things called night splints, which help to keep the foot and ankle dorsiflex to help to reduce the excessive stretch and strain on that plantar fascia when patients first get out of bed in the morning. Some patients find these hard to tolerate at night, so sometimes we suggest that they just wear it for a few hours in the evening while they're on the couch, again to help to stretch out that Achilles and that plantar fascia. There is physical therapy where I can send patients again for some deep soft tissue massage, soft tissue mobilization. They can incorporate ultrasound, which uses deep heat to help with soft tissue mobility, and they can even drive, there is phonophoresis or iontophoresis where you can drive some corticosteroid or anti-inflammatory medication through the skin either with electricity or with the ultrasound to temporarily help to reduce some of the pain. But again, you still need to control the excessive mechanics that cause the stretch and strain on that plantar fascia. There is cortisone injections into the heel. The problem with the cortisone injections is that they just temporarily reduce the inflammation and the pain, but as they wear off, the pain will return unless, again, you've controlled the underlying cause. And there are risks with cortisone injections. They can lead to atrophy of the fat pad, where you lose your natural cushioning in the bottom of the heel, or they can lead to rupture of that plantar fascia. So they need to be used very cautiously. Most people will get better conservatively with plantar fasciitis with supportive shoes, orthotics, and stretching. For some of the patients that have still some chronic plantar fasciitis that hasn't resolved with these conservative measures, or have had chronic plantar fasciitis where it's been present for several years prior to them coming into the doctor, there are surgical and non-surgical options. Surgical options would be a plantar fascial release. These can be done open or minimal incision. But they are associated with downtime, and again, releasing that plantar fascia has risks with it that you've essentially weakened the structure of the arch by releasing that plantar fascia. So you still need supportive shoes and orthotics to help to supplement that. And you've altered the patient's function of their foot by releasing that plantar fascia. A great non-surgical, non-invasive way of treating chronically inflamed plantar fascia is something called extracorporeal shockwave therapy. This is usually used for chronic plantar fasciitis, but is beginning to be used earlier on to help speed up the healing. When you have chronic plantar fasciitis, the tissue isn't as healthy as it once was. It's no longer in its acute inflammatory healing phase. So you have collagen degeneration. What the shockwave does is it's a procedure that can be done in the office or in outpatient surgery setting under anesthesia. It bombards that heel, the area of maximum tenderness, with about 2,500 shocks. That causes inflammation of the area. That inflammation causes increased blood supply, or the formation of neovascularity. So that increased blood supply helps with collagen regeneration, tissue repair. So you've helped to repair that chronically inflamed plantar fascia without releasing it. So long term, the patient's function is much better because you've helped to repair that plantar fascia rather than release it. But you still need to prevent the area from getting re-inflamed with shoe gear modifications, orthotics. And the extracorporeal shockwave therapy is usually about 80 to 88% effective. And again, there is no downtime associated with it, no changes in activities needed. We just ask patients, to avoid high impact activities, sprinting, lifting over 50 pounds right after the treatment. Again, we're causing inflammation, so they need to be off of their anti-inflammatories probably for about 2 weeks before and up to about 3 months afterwards, because the healing process continues for about 8 to 10 weeks even after your treatment.